Hi, my name is Dr. Neil Moody-Jones. I'm a GP working in the New Forest in Hampshire. I've made an EMIS web protocol based on the protocol designed by Dr. Robert Lewis, who's a consultant nephrologist from the Wessex Kidney Centre in Portsmouth. The protocol is designed to help encourage the annual testing of urinary ACRs in patients with diabetes, as well as the appropriate diagnosis and management of these patients, taking into account new treatment options. So here we are in EMIS Web in a demo patient, and there are actually 3 of my own protocols running, which I'm just going to give you a quick overview of. The first shows you immediately that this patient has type 2 diabetes, and it shows you where they are in their annual review process. So it shows you here that they're awaiting their invitation. If you put your mouse over, you can see their latest HbA1c, their latest cholesterol, the fact that they're not on a statin, they're not frail, and there's the date of their last annual review. This protocol actually filters the patients based on their blood results into either a nurse or an HCA appointment when those results come in. You can also see a suggestion here of considering metformin. That's run by a separate protocol of mine which suggests medication. That's because this patient is not on metformin, has got an HbA1c of 48 or above, and has got an eGFR over 30. And then my diabetic kidney disease protocol is running, and that's what's telling you here that they have no ACR in this QOF year. So I'm going to go ahead and add a consultation, and we're going to add a urine ACR. So obviously normally this would come down the wire directly from the lab, but we're just going to simulate that by doing that. So you can see that my alerts has changed and it now says DKD consider diagnosis. And if you put your mouse over the alert, it comes up and it says this patient has diabetes and a latest ACR of greater than 3 milligrams per millimole. A diagnosis of diabetic kidney disease should be considered. Double click here for more information. Now this doesn't happen with the current EMIS alerts, and it's a sort of a missing link, whereas what we found was there's a lot of patients with a raised ACR but who don't actually then go on to get a diagnosis of diabetic kidney disease. So if we go ahead and double click on that alert, we get taken through to a template. Here you can see things that you should consider before making a diagnosis of diabetic kidney disease. Was it an early morning sample? If not, you should repeat it. Are there signs of an infection? That could be influencing the result. Is their blood pressure controlled? You could consider treating their blood pressure first and then repeating the ACR. If you are happy that the above are not an issue, you can tick this box to confirm that they have microalbuminuria and then save the consultation. This will add them to the QOF register for diabetic kidney disease. And so EMIS will then provide alerts recommending the use of ACE inhibitors or ARBs. That won't happen here because we're in a test patient. But what you can see is that my alert has changed and it now says DKD consider SGLT2I. If you put your mouse over, you can see that it says this patient has diabetes and a diagnosis of diabetic kidney disease. Consider the use of an SGLT2 inhibitor with evidence in chronic kidney disease. Double click here for more information. So if we go ahead and double click, we'll get taken back to that same template we were at before, except now instead of getting the information about diagnosis, we instead get a section about management. This gives us general advice around metformin, statin, ACE inhibitor use, blood pressure targets, and then advice as to what to do regarding SGLT2 inhibitors depending on your different eGFR. You can see the patient's latest eGFR here. So you can see here the options that Dr. Robert Lewis's protocol recommends. We could develop this further to only show those areas relevant to the patient. So not showing these unless they had an eGFR in that region. I'm going to go ahead and save this one. and I'm going to put the patient onto canagliflozin. I'm going to change it to a hospital prescription so it doesn't actually print. And then save. You can see that the alert has now disappeared because the patient is now on an SGLT2 inhibitor. Hopefully you can see the power of a real-time alert like this. Thanks for watching.